Good afternoon, welcome. Thank you all for coming out. I think we are tremendously gratified by the interest in this topic and the work we've done. I'm Neil Chase, I'm the CEO at CalMatters, relatively new, 4 months in. Really appreciate you being here because CalMatters exists in order to do the journalism that has not been done here since some of the other organizations became much smaller and pulled out. So this is the kind of work, it's so important that we do it, it's so important that this kind of reporting and writing be done, and it's so important that you're seeing it, reading it, watching it, commenting on it, sharing it with people, and giving your feedback to us, and that you've come here today to talk about it. So we're very gratified and appreciate you being here to support us. We are streaming this online as well. We had a lot of interest, far more interest than we could fit into this room, and so we have an audience online as well with us today, which is great. I want to start by welcoming our partner here. The work we do would not be possible without the folks who support us and provide both the philanthropic support and the intellectual and content guidance to help us kind of do what we do. So I want to ask our supporter for this project, Sandra Hernandez, the CEO of the California Healthcare Foundation, to come up and say a few words.
Well, good afternoon, everybody. It's a real pleasure to be here and to see the incredible interest. I want to thank our panelists for agreeing to participate today and CalMatters for the extraordinary partnership that we've had. I guess I'll just leave you with sort of two thoughts as we really engage what I hope will be a very interesting and compelling conversation this morning. One is, I think everybody knows that in January, CHCF along with Kaiser released a poll from Californians, and for the first time really in the history, to our knowledge, access to mental health was the #1 priority in the body politic of the state of California. And I think that the theme today of a better vision for mental health being on the horizon is one that I think, no matter where you are in California, if you look at the data and the prevalence of mental illness and substance use disorder, we clearly have a compelling opportunity at this moment to really think about how we build a system that actually works for all Californians. We've built a system that is fragmented, it doesn't work well together, and whether you're trying to access it or whether you're working in it, whether you're working in counties or whether you're working in the state, I think everybody understands that California can and should do better, and in order to do better, we all need to work together to do so. And then secondly, since the beginning of CHCF, we have believed that health journalism is a very important element to good public policy in the state. And so we are very pleased to be partnering with CalMatters in a mental health conversation and look forward to today's events and future opportunities to work with them. So welcome to all of you. Thank you for being here. Thank you for your interest. And I hope what you'll hold in your heart is a notion that we can and should work together to do better. Thank you.
Thank you, and thank you so much again to the Foundation for supporting this work. This conversation follows on a series of articles that we've produced that took a look at some of these issues, I think, in a way that haven't been looked at recently. A lot of you read the work that Jocelyn Wiener did, and you'll hear more about that in a minute. On your chair is a booklet that has the stories in it, along with some of the commentaries. The whole body of work is here. Gives you a chance to look through it. It's also online. We shared it with a lot of our partners. The San Francisco Chronicle ran these stories on the front page. And this is not the end of the reporting on this topic, right? This is a point in time to stop and talk about it a little bit. Poor Jocelyn just found out she has more work to do. this is a point in time to stop and talk about it a little bit and get everybody's feedback and understand it, and then there'll be a lot more to come. One more piece that we haven't released yet, that'll be out soon, is a documentary that parallels the reporting, and I want to ask our video producer, Rhonda Lyons, to come up and tell you a little bit about the reporting that she's been doing on that documentary and show you a quick preview. Rhonda.
Good afternoon. Thank you for introducing me, Neil. As he stated, we are producing a documentary. The last shoot was this Saturday, so I'm in editing mode. This was one of the most rewarding job producing opportunities I've had. It really helped me grow as a producer, being empathetic, realizing that you are putting a camera in front of people's faces, being aware of their stories, and also being light with how you ask the questions and what you ask. And it was a rewarding experience, and I am so grateful that I had the time to really produce something. So without any more delay, you can look at the trailer.
He kept tapping me on the shoulder. Mom, look at that white car. That white car's following us. That's the government. That's the CIA. I remember saying to the judge in El Dorado County, I need help. He needs help, and I don't know what to do. We're waiting for a disaster to happen.
If everyone who showed up at my gym who have a membership, none of us could get to the equipment. But you shouldn't run a health system like that.
Not knowing where I'm going to go next. That's how I feel, kind of lost.
There has been a dramatic increase in the number of people in our jails and prisons who are mentally ill.
There isn't a big political action committee well funded for mentally ill people.
And so we have to do something different.
I feel like I'm also stuck in a vine.
So that's the sneak preview, and the full thing is available when? All right, can't get a date from you. It's going to be soon. So the work that went into this has exposed a lot of issues that we want to talk about, and we've asked Jocelyn to moderate a panel today about these issues. She's going to start by giving you a little bit of an overview, introduce the panelists, and then walk us through. It should be a fascinating conversation. You've got index cards on your chair. If you have a question, please write the question on the card. Somebody will be around the middle of the session to start collecting cards, and then we'll bring up as many as we can to get the questions in toward the end. With that, let me turn it over to our moderator. She's a longtime journalist in California covering these issues specifically with a lot of expertise, and somebody brought a sort of a unique perspective. There are not a lot of people on this beat. There are a lot of people who've committed a good part of their career to covering these kind of issues, and so it's especially fortunate for us to have her leading this. So let me introduce Jocelyn Wiener, and she'll take it from here.
Can you guys hear me okay? So thank you all so much for being here today. Here is what we know about the present. We know that suicides have increased dramatically in recent years. More than 4,300 Californians died by suicide in 2017, a 52% increase from 2001. Among teenagers 15 to 19, suicides increased 63%. We know that the largest psychiatric institutions in the state are not hospitals, they are jails and prisons. We know that about a third of homeless people, tens of thousands of individuals, are suffering from serious mental illness in our state. We know that the top health issue Californians want their governor and legislature to address is making sure treatment is available for people with mental health issues. At the same time, we know that California lags behind the rest of the country in providing mental health services. 37% of our adults with mental illness received services during the past year, compared to a national average of almost 43%, which also isn't that great. We know, in short, that something isn't working. But what? and how do we begin to fix it? This is a conversation that merits much longer than the hour or so we have. Nevertheless, let's try to use our time to consider how our state's mental health system could evolve in the coming months and years. What are the biggest barriers we face? Where are the models of hope that already exist? To talk about these questions and others, we are very lucky to have assembled this wonderful panel. Kelechi Ubozo is a suicide attempt survivor and mental health advocate featured in the SAMHSA award-winning documentary, The S Word, as well as several other national television programs. Kelechi's first book, We've Been Too Patient, Voices from Radical Mental Health, will be released this summer. She currently works at the California Mental Health Services Authority as the Peer and Community Engagement Manager. Senator Jim Beall was elected to the California State Senate in 2012, where he represents the 15th Senate District, which includes Silicon Valley. Senator Beall has authored legislation to help foster children, low-income families, and people with disabilities. He has worked on the delivery of mental health services, supporting laws to increase enforcement of mental health parity and to curb the over-medication of children in foster care. Dr. Tom Insel is a psychiatrist and neuroscientist who served as director of the National Institute of Mental Health from 2002 to 2015, overseeing the federal government's investment in research on mental illness. Over the past 3 years, he has worked in Silicon Valley, first as the mental health lead at Verily, and recently as co-founder and president of Mindstrong Health, a digital mental health company developing tools for people with serious mental illness. Carrie Morrison managed the Business Improvement District on Hollywood Boulevard for 2 decades. Her work brought her into contact with people suffering from severe mental illness. She became increasingly frustrated by a system that seemed to her to protect rules and regulations at the expense of human lives. She received a 2-year Stanton Fellowship from the Durfee Foundation to do a deep dive into this problem. That experience led her to Trieste, Italy. She is now devoting herself to sharing how Trieste-inspired principles might revolutionize our country's mental health system. Alex Briscoe is principal of the California Children's Trust. His work has focused on the design, development, leadership, and reform of behavioral health services and strategies in California's child-serving systems. He is a former director of the Alameda County Healthcare Services Agency. Because time is tight and we want to cover as much ground as possible, I'm going to ask the panelists to keep your answers relatively brief. I'm hoping you'll all weigh in on my first 2 questions, but feel free to skip any others if you'd like. Given the wealth of knowledge in this audience, I'm hoping to leave ample time for Q&A. So, ready for the first question, panel? The first question I have is, what do you see as the root of the problem with mental health services in the state? Is our system broken, and can it be fixed? Anyone want to take a stab at it first?
Well, I could take a quick stab at it because I want to be very succinct. The biggest problem is discrimination. Discrimination is applied to not only what we do in Sacramento here, the process of reviewing bills and the budgets and all that kind of stuff, but also in the community and the people's attitudes about mental illness and the mode of treatment that people prescribe due to their discrimination and their prejudice and their stigma. And it starts at the youngest possible age with young people in the schools. It's applied to you when you're at work. It's applied to you in your public discourse. And I think people have prejudices that are systematic that we have to deal with in the mental health area. And it just exhibits itself in so many different ways. The criminal justice system, the social service system, the health system. And the bottom line is it results in a lack of delivery of service. and treatment for people.
You know, I like Senator Beall's answer. It frames this more as a civil rights issue, not just a healthcare issue. And I think there's real power in thinking about this in terms of discrimination and social justice and how we can broaden the conversation. I'm new to California, so I'm still learning about what works, what doesn't, who does what. But I have to say, I think what strikes me most as somebody who's still kind of getting the landscape is, I guess succinctly to say, the lack of leadership here. It's, you know, like trying to play the piano with 58 fingers. It's really hard to figure out what is the state trying to accomplish. So in many states, you can go to the state government and there is a set of very specific goals, numbers and timeframes for accomplishing those goals. In California, maybe there's someplace I haven't seen a statewide commitment to reduce suicide by 15% in 5 years, or to ensure that there's a 20% reduction in the number of people with serious mental illness who are ending up in the criminal justice system. Other states do that, but in California, if it's there, it's not apparent to most people that I talk to that we have a set of very time-bound, specific, quantitative goals that we're trying to reach as a state. We often say in the business world that, you know, you can't, if you don't measure well, you don't manage well. You can't manage what you can't measure. And I don't see the leadership around measurement and accountability for specific goals in the state in terms of helping people with serious mental illness.
I'll jump in. When I was awarded a Stanton Fellowship a couple years ago, I had, 2 minutes to describe what my inquiry was for 2 years. They gave me time to leave my job, and I said, this is our mental health system, and I'm going to try to spend 2 years to figure out how to pull off the rubber bands, which are all the rules and regulations and risk management and HIPAA and billing requirements and whatnot, to try to get to the person on the inside of the ball. And so I spent the first year looking at America for how to take all these rubber bands off. I ended up in Trieste, Italy, where all they see is the person, and there are no rubber bands around caring for that person. So that's what's wrong with our system right now. I'm not sure the current system can be fixed.
Well, I don't know if you all can hear me. Can you? Okay. Hi, everyone. So I'm a person who has lived experience of mental health issues and suicide attempt survivor and all of these things, system involvement. And from my vantage point, I would say that the mental health system keeps doing the same thing over and over again, expecting a different result, which is unfortunately, as we all know, the definition of a very stigmatizing word called crazy. And so we're doing the same things that are traumatizing people, like forced treatment, hospitalization. Having 911 be your first responder is not working very well, you know, especially for communities of color who that is the last choice that you would ever want to make. Could we have a different 3-digit number that serves folks? I think when you think of lived experience of folks who have been in the system, who've experienced the system, and not integrating it at every single level, I'm not talking about a tokenized role, I'm talking about really changing the system. We're not going to fix it unless we do it together. And that also includes our family members. We need to be working with folks who have lived experience and those folks, their chosen family, to help this work. But as we're currently doing things, we have so many resources, we have so many ways of looking at things differently that we could really be doing. We are a very, very wealthy state. And so I don't think it's about resources. I think it's about how we leverage those resources to reach the folks who are in the system, who have a lot of feedback about what that should look like. And we should be included at every level.
That's good.
Good morning, or hello, everybody. I think you asked about the cause, and I would certainly agree stigma is an essential component of it. But there's some deeper causes that are driving the data that you referenced, including structural racism, systemic denial of opportunity, the extension of adolescence, it takes longer to get into the workforce, and a historical broken approach to Medicaid in California, where despite being so wealthy, we rank 48th in the nation in spending per beneficiary. So you asked what are the causes. I think we have to both look at our own, kind of the more overt ones like stigma and lack of sophistication in organization and delivery, but also some underlying ones that we have been unwilling to name and take on as the charge of the mental health system, like structural racism and the stabilization of poverty.
So the next question that I'm hoping everyone can answer is about solutions, since we're here hoping to talk about hope on the horizon. I'm curious what gives you hope, and if you can tell us about some of the innovative ideas you think are already out there that could help address these problems.
I'll go first, just because there's 5 of them right there. The pool of consumer champions from Alameda County. And as was previously referenced, there's an extraordinary amount of wisdom and intelligence in the people we serve. We just don't go about asking them. And as Sandra said at an event on Friday, public systems that aren't accountable to the people they serve don't work. And there's really no viable mechanism for people in Medicaid to have a substantive and honest conversation about the operations of Medicaid. So I think that the biggest and most important opportunity before us is much more direct and specific engagement of those with lived experience.
Yeah, if I can jump in on what Alex was just saying, I think we've, in spite of having this very fragmented delivery model here, we've got great experience, and there are some gems of things that have been done in California already that we can learn from. It's hard to scale them without finding a way to cross county boundaries and to make sure that the best practices get used by everyone everywhere. But certainly there's a lot to mine and a lot to learn from. I'm also particularly hopeful because I'm a physician, so I look kind of broadly at where we are in medicine. And for large areas of medicine, the problem we have is we don't know enough to do better. And so if we were here talking about ALS or Huntington's disease or even Alzheimer's disease, it would be a question about how do we get the science that we need to find the answers that we need. What makes me especially hopeful here, but also incredibly frustrated, is that we know what to do for most of the issues we're facing. This is not a problem that's an R&D problem in the classic sense. We don't have to find the brain mechanism or the molecule or a new drug. We have to figure out how to implement on the things that we know about. How do you close the gap between what we know and what we do? And that's a execution problem. That's a policy problem. That's a problem of public interest and political will, which, while it is difficult, it gets back to Senator Beall's proposition at the beginning. It's a matter of commitment. It's a civil rights issue. So I think I'm actually hopeful that this is doable if we as a society, as a state, decide we want to make this a priority. We can do it. We can do it better than anyone's ever done it. This could be Camelot for mental health based on what we know right now, without having to come up with any new magic bullet.
So I might disagree with that because, and I'm not a doctor. I'm a community person who watched for decades people with mental illness wander down the Walk of Fame barefoot, talking to the storefronts, and there was no systemic accountability for these people in our community. So I agree, it's not rocket scientists in terms of what people need: a connection. They need a place to live. They need their social connections. They need support. And what I witnessed in Trieste, and I'm just going to use that as it's almost like being in a biosphere bubble of a place where people are treated so differently. They're not in jail. They're not in the psych hospital. They're not homeless. they are truly cared for in the community in a much less cumbersome way than we expect our mental health workers to carry out in California or the United States. They don't have the myriad rules and regulations and risk management or risk-averse rules applied to them. It's a 24-hour system. The police are never the first responders. They are the last people you would call into a crisis situation. You would call in peers or psychiatrists or trained professionals. Having seen this and have been there 4 times and seen the dignity and the humanity, we have got to roll things back in our country to actually focus on people as human beings.
I would mirror that comment. I think there's a lot of things that give me hope, and it's the folks in this room. There's a lot of folks working in grassroots organizations, really supporting people, and the resources don't get to them because maybe their program isn't technically evidence-based. And what happens when something becomes evidence-based or these universal interventions? Well, they might work for someone in Milwaukee, but they're not going to work for someone in Oakland. So if we were able to provide the resources to our community to maybe do participatory action research where we utilize the peers and community to help us find the solutions that they're already doing. There's so many solutions, they just don't get funded. It really isn't rocket science in some ways because the solutions exist. It's just that those folks are really, really working and almost at a burnout level, not able to take care of their own mental health because they're serving all these other folks. That also looks at what's going on with Medi-Cal, Medicare. We're not able to bill for culturally responsive solutions. We can't bill that. It gets in a PEI bucket and you can't ever bill a service for that. How is someone supposed to be sustainable as a nonprofit organization doing grassroots work if they can't bill? And if our whole system is built on, if it's not billable, it's not happening, then we don't actually we have the solutions, we can't fund them. And so then what happens? Another organization runs out, someone else gets a contract, et cetera, et cetera. So why aren't we partnering with the communities who have those solutions and finding a way to have those solutions become Medi-Cal billable? I believe there's some, I think it's AB 512, that's looking at cultural responsiveness and also Medicaid and how we can bill differently. And I'm sure Senator Beall is going to talk on this, but SB 10, our peer certification, you could actually utilize peers and peer service delivery, which also includes family members as well, and you could maybe build peer respites and those sort of things that are not traumatizing to folks. Because what I will say is that folks who have been hospitalized, that is, and I have research on this, so I can give it to anyone after this. I know some folks really love data. That's an indication that someone will have another suicidal attempt is hospitalization. So why are we still funding the same thing that doesn't work? Let's do something different. Let's build a vision together of what it could be and look at the communities who have the answers. There are a lot of leaders in this room. Y'all should be on stage. You know what I mean? You have a lot of solutions. So thank you.
Well, I'm kind of excited about the new governor because he's actually talking about mental health and substance abuse. And I say substance abuse too, because that's part of, we got to throw that in there. That's part of it. And he's actually put money in the budget for workforce training, school-based programs, several other programs. So I'm kind of excited about the start, but we need a top-notch mental health czar for California to help guide the governor on his, as was said earlier, leadership that we need. We lack that leadership at the top. We've lacked it for so long in California, we don't even know what it's like to have a leader in California. We don't even know what it's like to have the governor of Pennsylvania get up and say, every healthcare provider in this state will not have prior authorization for medication for substance abuse. The governor stood up and said that. You're not going to do it. We're going to make sure that you do not have prior authorization for medically assisted treatment. We have governors in other states that stand up and have pronouncements and takes that leadership. We need Governor Newsom to continue to be a leader and maybe be a profound leader, possibly, and not get diverted and not get drawn down by the inertia that exists. Inertia, what I call discrimination. Inertia is partly a way of discriminating against people. Omission is the worst type of discrimination. Not doing something, not supporting something. It's not that you're opposing something, but you're not supporting something, you're not doing something, you're not talking about something. And I think for a long time in California, maybe going back 4 or 5 governors, think about it, 4 or 5 governors. Some people in the room would know the history. We haven't had anybody to really talk about it in a profound way. We don't know what it's like to have a leader in California on mental health. Unless you're maybe older, like my age, maybe you're Senator Don Perrott in the back of the room, pro tem, who was around in those days, but maybe Don can unretire and become the mental health star. I mean, how many people here would like to be the mental health star? We have any volunteers? Raise your hand, come on. Yeah, right here. I mean, we need people like her or, some of these other people in the room probably to be the mental health star in California. And we need Governor Gavin Newsom to continue to support and demand changes in that. And that's kind of an important message here. And I can only do so much as a senator, chairman of the Senate Select Committee on Mental Health and Substance Abuse. I can get my colleagues all excited about it, but then if the governor and his people are not talking about it or not doing anything about it, it drags us down. So anyway, I think we need the governor to take hold of the issue, grasp it, and follow through with it.
Thank you all for that. So I have a lot of other questions. You guys are welcome to answer or not answer, depending on if it moves you. The next thing I wanted to ask was about children's mental health. Hospitalizations for children and adolescents for self-harm and other mental health-related concerns have shot up by more than 40% in the past decade. Even as a growing percentage of adolescents reported experiencing depression in recent years, less than a third reported receiving treatment. So how do we better serve our young people?
Ask them. Because I think one of the things about empowering people, as we were talking here, empowering people makes the solution come to the obvious level, right? So I think asking young people about what the solution is, peer groups for young people, creating those peer groups in all the communities. We have SB 10, the peer provider certification. Bill got vetoed last year. We went through 40-0, 80-0, got to the governor's desk, boom, it got vetoed. Okay? So we got to get that bill signed. The SB 12 is the youth drop-in center. Young people don't like to wait for appointment. You can't tell them there's an appointment in 3 months. They want to have immediate access. So just a walk-in, immediate youth drop-in center. We funded a couple of them in the mental health. Katara is the chair of our commission, the Mental Health Services Act. We funded 2 drop-in centers. We want to have 100 in the state of California. So we want these youth drop-in centers that get immediate service. And then programs in the schools. The programs in the schools are necessary. Teachers need to be involved in mental health, behavioral health issues. And then early childhood screening and evaluations. If we can find out the earliest possible moment and get involved in screening and evaluations at the earliest possible moment, that's got to happen. And then, of course, the prenatal programs with the mothers, preventing Prenatal programs are very important. They can be a preventive program for mental health problems. So those kinds of programs is what I think for young people.
We used to have a Surgeon General, Rich Carmona, very outspoken guy, terrific leader, used to distinguish between healthcare systems and sick care systems. And his argument would be that we have a sick care system that we're dealing with here. Sorry about that. The question of how to get there earlier and what can be done largely comes down to how do you arrive at the scene? How do you get to where people are? And part of it is asking them what they want. Part of it is having a workforce prepared to do that. This is not a healthcare question in the brick and mortar healthcare sense. It's trying to figure out how do you create opportunities for kids in the school system, off after school. You want to know how to do this, go to Australia. They've figured it out. They've got a really wonderful sort of two-part system. There are the kinds of centers like we're starting here in California called Headspace that are throughout the country, have already shown some impact on for teenagers. But even more importantly, they've begun to put in place something called future-proofing, which is the services and the education and the culture change that takes place beginning at 7th grade. So that everyone, this is population-based in the entire state of New South Wales, which is where Sydney is to become part of this new opt-out program. Pretty interesting. There's no reason California can't take on something like that and lead in the same way and create a very, very different future for using not the traditional healthcare world that we're used to, but using education as the platform for that.
Maybe I could just quickly pick up there what Tom was saying. I think to address the youth mental health crisis, you actually have to redefine what you think of as mental health and align your payment systems with that redefinition. So if you think of mental health only as a response to pathology, you get what we got, which is per minute, per unit, diagnosis-driven treatment. And so I've billed Medicaid and juvenile justice and child welfare on a 911 rig, and I was a county health director. There is no Medicaid reimbursement system more complex, more arcane, and less aligned with best practices than behavioral health Medicaid reimbursement. So all of the things that the two speakers just said are so true and so right, and the system currently doesn't pay for those. So until Medicaid does, to Tom's previous point, we actually have great practices. 6 million of California's 10 million children are now in Medicaid and eligible for a federal entitlement that guarantees them everything they need. And only 4% are getting anything at all, regardless of how good it is. So in order to reinvent children's mental health, you have to think of it not as a response to pathology, but as something that happens everywhere where children live, work, and play.
Absolutely. I think I would just, yes, definitely clap for that. I would add that among the things that should be funded, like we should really think about restorative practices. I mean, I haven't been a young person for quite some time, so you should ask young people what they want. But when I was, a lot of the mental health challenges I was going through was because I didn't have any social emotional skills. I didn't have any coping skills. I didn't know how to deal with what was going on with me. And being, put in a hospital and told that I was broken wasn't helpful. What would have been helpful is these restorative practices that should be funded, where it's really focused on changing school culture and really focused on building up that, that net so that person can actually build their social emotional skill set and their coping strategies, because that's something that all youth and all people really should have access to. Those are the things that are really helpful. And so better than like a one-off mental health first aid training for teachers, how can we focus on changing culture in the classroom to be really more responsive to building that social emotional health skills?
Can you all hear me now? Yeah. Okay. So now switching gears a little bit, I wanted to ask about funding. Since the governor has said that our problem is not a lack of money, but rather how money is being spent, and the Mental Health Services Act has injected billions of dollars into the state's mental health system, So I'm curious, what's your take on this? Is mental health funded sufficiently in California? Is our issue money, or is it something else?
Well, I'll jump in. What we're going to try to do in Los Angeles County, excuse me, and we have a proposal going in front of the OAC this Thursday, is to take a pilot area, a defined area, Hollywood, 110,000 people with a very defined boundary, and pursue an approach whereby we would set aside the fee-for-service Medicaid model in treating people in that area who have a mental illness, and have it be based on a per capita rate, a multi-tiered rate based on level of service, to free up the staff in the system who, as I understand it, are burdened by, as has been described to me, soul-crushing documentation, which takes them closer to their keyboard than actually serving people. So the notion will be to move to a whatever it takes model to provide whole person services to people that might be beyond the traditional medical model, and to free up the system to allow for that level of care and intervention. So we are bringing this proposal on Thursday to the state to consider supporting this 5-year pilot.
At the risk of taking issue with this extraordinary new leader we got, I think he's actually wrong. It's not state funding that's the problem. It's federal funding. So you might ask, how are we 48th in the nation in spending per person when we tax ourselves at one of the highest levels of any state in the nation? And Medicaid is a pot of gold sitting in DC. You get $1 when you put up $1. We're putting up lots of dollars. We're not going and getting the other one. So the ethos of what the governor is saying is correct, that the state is putting up its fair share, but it is not administering it effectively or intelligently. We're spending lots, not getting enough federal match, even though particularly children are entitled to it.
Yeah, I would second that, Alex. I think that if you look carefully at what we've done in California relative to other states, we haven't asked. We don't have the waiver requests that you'd see in Florida, Missouri, Maryland, Massachusetts, lots of other states. So we're leaving money on the table. The reason we're 48th in beneficiary is because we're not aggressively looking for the funding that's actually put aside for just that purpose. Now, CMS may not agree with that. If you ask people in Washington, you may get a different answer to that question. But I think the numbers speak for themselves. We do spend a lot of state money on mental health care. So we're almost to the $10 billion mark per year in this state, which does seem like a lot. So one has to ask why we haven't done better on the federal side. And I think that's part of the leadership issue. It's part of the fact that there isn't really a priority for figuring out how to do this so much. There's no real state mental health presence to make that happen. And that is very hard to do county by county.
I just want to say that I want to ground us in what the Mental Health Service Act, like the spirit of it, was really from consumers, advocates, family members. And part of that original, like when it was drawn up, was really thinking about what does a community planning process look like? What is the need of the community? And I think what's happened sometime, and depending on your county, depending on how many resources you have, the folks who should be in the room for the planning aren't there. And so the needs that are supposed to get met don't get met. And so for me, I don't know, I mean, there's definitely the Medi-Cal challenge, and that's also something. But when you think about whose needs are you trying to meet, sometimes you'll get the same providers coming in looking for their same pot of gold. And really it's like, is this matching what our needs are? And it's not like someone has this rigorous like data structure that has helped counties figure it out. Like counties don't don't have like researchers sitting there like analyzing everything. Like there's definitely some resources that need to know, like, are these effective? And if the challenge is, if you still have all of these hospitalizations or like racial ethnic disparities and all of these things that are still not working, it's because you're not meeting those folks. Those folks are probably not part of your community planning process. So it is partially something that I think counties should take accountability of and think about how can they leverage those folks in their communities who they're not serving. Who are those cultural brokers that they can work with? Who are those consumer-run organizations? Where are those folks? I mean, think about the California Racial Disparities Project. There's lots of pilot projects that are going on that might be working on these grassroots levels that aren't getting any attention or support. And we're also tasked with serving these communities who are underserved, or in, for example, my county, Alameda, inappropriately served in like hospital and jails, for example. Like, I don't know why we all Black folks always end up in the jail setting getting mental health services. That's not where we should be getting services. So we should look at the data that we have and see what's working, what's not working, who's not part of the conversation, who should be part of the solution. And we should also get Medi-Cal funding as well, and Medicaid funding. But like those community planning processes can be a lot more robust and a lot more inclusive, because I really think there's really grassroots solutions. And the last thing I'll say about that is a lot of folks are trying to meet their basic needs. Like the housing crisis is really a crisis. So if folks aren't coming in the door, it's like, oh, hey, mental health is a privilege that I don't get to have because I need to pay my bills. We don't ever think about like, how can we look at the intersection of poverty and mental health and see if we can find ways of like, okay, maybe you need some housing support. How else can I get some support for you too? Like there's other ways to do stealth mental health for folks. And having housing really helps people's mental health.
Jocelyn, if I can jump in, I'm not sure it's the right question, really, to think about the money at this stage. It feels to me like we're always jumping to try to understand the financing and the mechanisms and the complexity of this. We're at a really interesting point in time, not just that we have a new governor, a new opportunity, but we're a year or so away from the whole revisiting the waivers for Medicaid. We're potentially looking at whether the Mental Health Services Act itself should be refreshed in some way, and asking that question. I mean, in the next 12 to 18 months, there's a lot we can do, but I think we should be asking ourselves, what do we want? What do we want the state to look like in 2024? What are the goals? And then we can try to figure out, once we know what the what is, the how we can work out. We can figure out whether, does it need more money? Does it need less money? Does the money need to be spent in a different way? But I would put that question after asking the question, what are we trying to do here? What is it that we want to look like as a state with respect to homelessness, incarceration, hospitalization, all of these issues, employment, education? Where do we want to be in 2024? Decide as a state, and this is a very inclusive process, what this needs to look like, and then figure out how to get there. We do have the opportunity in the next year or so to figure out the mechanisms, but I think first we've got to get the what, and then we can get the how and the when and the why and all of that laid out. But I would love to see a process, and maybe this is the beginning of such a process, to begin to spell that out very clearly. And it's not going to be 100 different things, but what are the 4 or 5 things we want for our state related to behavioral health between now and 2024?
Thank you.
Yeah, I have one just quick comment, because I'm in a lot of pain right now because my Parity Bill was defeated for the 4th time last Thursday, so it hurts. I tried 4 times, and it's actually getting harder to get it passed. Before, I brought it to the governor 2 times, and Governor Schwarzenegger vetoed it twice. But the last 2 times, it didn't even get out of the Senate. My own colleagues killed the bill. So the Democrats have to have a message, if they're going to be in charge of this state, that mental health has to be a priority.
Yeah.
And I think that's what we have to tell them. And if they don't want to make it a priority, look at those poll numbers, and maybe you'll find that you might not get reelected because people are paying attention to you on this issue. If you take away Proposition 63 and the federal funds, and you look at what's left in the state budget for mental health, it's in the California prison system. That's where the money's going. It's not going to the community. It's not going to kids. It's not going to preventive programs. It's going to fund the court-ordered mandate that they fund mental health programs in the California prison system. And that's where we are right now. So if you think the system works, you're dead wrong. It doesn't work. We have to start from scratch. So we need that start from scratch attitude about it in the state.
So I have like 20 more questions that I'm not going to be able to ask. I am going to let myself ask one more question, and then I will give the rest of the time for Q&A. So if you haven't handed your card over, please do. But the last question that I'll ask, at least right now, is where the leadership for this should come from. I hear a lot from people. I hear you guys saying that there's not enough leadership in the state and that there hasn't been. So I'm curious, like, what could change in that? And could it change at the state level, at the county level? Is it at the community? Like, where is this leadership coming from, and how can we elevate the voices that are being marginalized right now and elevate, the actual lived experience of the consumers into something that looks like a cohesive policy?
You're the one that brought it up. You should answer that.
Already said.
Thank you, Kelly.
Already made my comment.
No, I think you've answered it, Jocelyn. I think that it's leadership isn't just a person. It's really going to be at every level. I mean, the power of community here is so essential. It's got to be a process that, and the leadership is all about having a shared vision. So I guess the question becomes, how do you start that process? And it feels to me like CalMatters and California Healthcare Foundation are doing precisely that. Right? You're starting, and this is where you can be really effective as a journalist. You can begin to open people's eyes. It's so clear that everybody becomes an involuntary expert in this problem because we all experience it personally. We don't talk about it, we don't share with each other, but there isn't anybody who's untouched by this. I remember being on a panel once with Patrick Kennedy, and somebody said, well, what is serious mental illness? And he stopped for a moment and he said, serious mental illness is any mental illness that affects somebody you love. Mm-hmm. And it was about at that moment when everybody in the room realized that they were touched by serious mental illness, because every family is in some fashion. But we don't really talk about it. It's still very much a sort of basement issue. I don't say basement issue because people in California don't have basements, but it's not an issue that people talk about in an open way still. And that is where journalism helps, providing leadership. It's where community helps to give people a place and a space to do that. And it's where government can help by providing the right policies. So it's at every level.
Yeah, I'd like to echo that. And I do want to thank CalMatters for taking the lead on educating the public. I had like 10 people send me your articles, so it struck a chord, and it was very readable, very approachable, understandable, because we all get asked all the time, how did it get so bad? Why are we in this space? And to the Senator's comment, people are noticing there is huge frustration, at least in Los Angeles, at the human misery that is playing out on our streets, and people don't know where to go. Who can we call? Why are these? And it's human misery to the point of rags and bare feet. It's shocking for tourists and visitors and just regular people to see this chasm of how people are treated in our society. So kudos to you, and kudos to everyone who's taking a place in this space, because I think the public is ready to be enlisted in this.
I think we have to build a vision together. I think that means it might mean some people lose, but we have to come together and bring these disjointed systems that someone gets funneled here and then referred there and then that happens over there. Do we have to start from scratch? In some ways we might need to, because we need to look at our funding streams. We need to look at creating a vision that makes sense for us, and we really need to integrate those folks who are most impacted by the systems, those folks with no shoes, those homeless folks, those folks like me, those folks like the POCC, into the solution. Because I'll tell you, there's a lot of boards, a lot of places where you get one consumer voice, but it's not going to take one consumer voice. It's going to take a lot of consumer voices, a lot of family voices, a lot of provider voices working together for the betterment of us all. We have to do it together. And we also have to partner with the criminal justice system to then not partner with the criminal justice system, if that makes sense. Let's undo that situation.
Yeah.
And that would be part of building this vision.
Yeah, I'd like to make a quick comment on just the practicalities of it, Jocelyn, because I think you asked this great question, which was how would the lived experience drive a reform agenda? And I think until you formally and directly tie it to decision-making and reimbursement, you're tokenizing it. So what I mean by that is things like patient satisfaction should drive incentive payments and contracts. There should be some direct and formal obligation of assertive community action teams to have peers on them. It shouldn't be the exception, it should be the norm. The idea that when you get discharged from psych emergency, a peer calls you within 24 hours to make sure that you have a follow-up appointment should be an expectation of the state's Medicaid system. So my point on this is that unless you actually tie it directly and specifically to how Medicaid works, how you measure its effectiveness, and how you pay people, it's going to be a token.
Questions?
Okay, so now I have questions from the audience, and that includes people who aren't here but are watching the live stream. So anyone's free to take a stab at these. What agency can take the lead to define the mental health infrastructure and identify the gaps in service area?
This is a softball for me. There's a single state agency under federal law. The problem with MHSA is that as long as Medicaid is a failed state, it can never succeed. It's $2 billion. Medicaid's $14 billion. So it's like the scales of history are going to weigh this way. So I think instead of engineering around our health department, the health department needs to be empowered, freed, supported to achieve its mission and obligation.
The governor. We tried to work it through the bureaucracy. It doesn't work. I think the governor, we need a total radical change. And the governor has to get involved in the details and make the changes. He has to spend some time on the issue.
Next question, how can we create more regional multi-county efforts?
Yeah, maybe I'll jump into that. I think we're already in the process of doing that. Certainly for the managed care piece of this, it already is regional, 26 regions, 26 systems, not perfect, but you have good examples of this, 14 northern counties under a single contract, which seems to have worked pretty well. It's different, of course, for the specialty mental health care sector, which is still county by county. But even there, within the MHSA, the Oversight and Accountability Commission with CalMesa has begun to create these interesting partnerships for technology. You heard about one a moment ago around early psychosis. There are a number of these that are beginning to aggregate. There's still experiments. One would hope that it would become easier to do that. I think it is a great question about whether there are ways to pool resources across counties, especially in issues like building the workforce or creating good data systems, things that you just don't want to do 58, or actually it's 56 different ways. It's just so much easier to build this once instead of over and over again.
Part of the brilliance of the MHSA, like the spirit of it, is that there's innovation projects, and one of the innovation projects called the Tech Suite Project does pull together 15 counties as a collaborative to work together to find solutions around technology to maybe interrupt and support folks who need services when they need it at their fingertips. And so, having the opportunity to try something new, try something different, and then also evaluate what works, what doesn't work. Because with any innovation, you do need, you do run along bumps along the way, but utilizing innovation projects as a way to try different things and then trying to then, if it works, then spreading that out to the other counties. So we do have things like that here.
My way of doing it would be to the managed care health plans that are in each county for Medi-Cal could create these consortiums with maybe the bigger counties being the so-called mothership, and the big counties can work with the smaller counties in a teamwork fashion to provide the specialty individualized care for people in the far reaches of the state that need to have services for people with special needs that can't be provided. And we can also instill in the system that way cultural competence and more individual care treatment models. So that's what I would do.
Next question maybe is somewhat related. How do we solve the fragmentation of the mental health system? So many good things are happening, but no one gets all the information they need.
So one of the innovations, I don't know if this will be responsive to the question, but one of the innovations we're going to propose in the pilot is something that we're calling a system concierge. What we have found in tracking people who have been moving through the system in Hollywood, and I'm coming from a place of as a layperson teaming up to try to help people get off the street, is that as they would move through different parts of our system, maybe 5150 into a hospital, then they get released and nobody knows they've been released. Or maybe they enter into a conservatorship proceeding and they're placed in a hospital somewhere, nobody knows where they are. Or maybe they end up in an IMD and nobody knows where they are because they won't tell the family and they won't tell the supporters. So we would constantly be trying to find where people were who we were following through the system. In this pilot we're proposing, there would be a system concierge who would be watching where people are entering, leaving, or accessing the system. And there would be the ability for supporters, friends, family, others to engage with the system concierge to be in support of that person. Right now, people are just kind of left to their own devices often, and we need to create kind of a cohesive way to stay in touch with them. So that is one way that we're going to look at it in this proposed plan.
I'd like to, I got two thoughts on this. First is Tom's point, is that it's better to be a laser beam than a fluorescent light bulb, and that the state should give some leadership over specific targeted topics that every county mental health plan must achieve. So I think there's a state leadership function. But on the practical level, we have to use common assessment tools and common language. And on the hopeful front, The child welfare system and the mental health system, for the first time in the state's history, adopted the same assessment tool, the CANS. That's an extraordinary achievement and an incremental change that we should be celebrating. And that same tool should be adopted across the other child service systems, including education, juvenile justice, early childhood, and elsewhere. So I think until we are using the same tools, using the same language, and have specific and direct leadership from the state, we're going to get the kind of balkanized system we do.
Well, I think it's great to build on some successes. Child welfare is really interesting to look at because they've really done this, as you know. They've really put together a program that does measure in a dashboard on any given day. You can look at where you're at for every kid in the state. It's pretty impressive. We're not there yet. I think here for the mental health care system, you still want to remember that there's several levels of fragmentation. So there's certainly the divide between mental health care and still substance abuse care, mental health care and primary care, within mental health care between serious and mild and moderate. So you've got, it's not a single solution perhaps for all of that. I love Kelly's idea of making someone accountable, someone who can be the coordinator for all of that. And it'll be interesting to see how that plays out. There's also the way, there are ways of reorganizing. So Senator Beall's idea, which is kind of what has been done in Washington State, is to create these kind of centers, the motherships that are regional, that are responsible for bringing a lot of this together. But we can do it. There's nothing that actually keeps us from doing it except us. We have to decide that we want to fix this and create something that works a lot better than what we've got now. I haven't heard a lot of cheerleaders for the status quo, so I'm hoping that there'll be some energy to try to make things a little better.
So this is a question about changing the administration of MHSA funds to stop counties from supplanting rather than providing inventive direct services.
Well, they shouldn't supplant. If they do, they will be arrested. Right, Madam Chair? She's the chair. I'm on the commission too. So they're not supposed to supplant. But we have to enforce that, right? That's our job. I mean, we should be enforcing that. The law is that they can't supplant and they have to use the funds appropriately. And of course, we did the audit and now we find that the expenditure of the funds hasn't taken place in an efficient manner. So part of it is to get the money out there where it's supposed to be spent on the services. That's what money's for. So.
And I think adding to that, really looking at your data and seeing where in your budgets are public. I mean, they should be. They're posted.
They are.
And so I think part of that is maybe supporting counties and having that data support and reporting that to the OAC, and then having the OAC partner of okay, what happened? Because it is public funding. This is taxpayer money. It needs to go where the need is, which goes back to having a robust community planning process that's focused on need, not money. If you focus on need instead of who's getting what dollar, then you can focus on the solutions for the need. But when it becomes this interesting political budget situation, you're not actually solving the problem that the funds were intended for in the first place.
Sorry, this is going to be unpopular, but the problem is if you're a local mental health system, you get your money from new cars in the mall, vehicle license fees and sales tax. So when the economy turns down, and remember those dollars, those are from realignment, 1991 and 2011, those dollars dwarf MHSA. So like in 2008, when we had a big economic downturn, those of us who were running safety net systems got the rug pulled out from underneath us. We had no money to do things like get the ambulance there on time or run like emergency. But millionaires kept getting richer. So what happened is because Medicaid is so dependent on these sources that drive to the local level that are so exposed to economic downturns, MHSA became the sort of thing that saved local mental health systems. So that's what I meant when I said if Medicaid doesn't work, MHSA will always be kind of its handmaiden, will always be its apologist. And so I think unless we rework how dollars flow to the local level, MHSA will always be imprisoned as the apologist for the Medicaid program.
Yeah. So can we just make, before we go on, I think we should be clear, because there's this, I keep hearing this in every session I go to, that we've got all this unmet need and we've got all this unspent money. How can this be? Right? And what's wrong with the counties that they're not spending their money? And I think it's worth really looking deep into this, because I'm not sure any of us fully grasp what the financial situation is. First of all, it's very different. Many counties have no reserves, right? So would be a mistake to assume that everybody is sitting around with a stash of cash that they don't want to spend. There are some counties that have sizable reserves. There's a legal requirement to have a prudent reserve, which is like 33% or something like that. So that has to be there. And then there are some counties that look like they have a huge amount of money, but those are monies that are encumbered but not yet spent. So I can tell you, as I've tried to understand this question of how much money is actually sitting there unspent and can't be applied to this unmet need, I don't think it's that easy to answer. I think we haven't done a great job of making that as clear as it could be, even for ourselves. So it does become a county by county question. And I would just, for those of you who walk around with this assumption that the counties have just been unable to spend all this money and they have so much surplus cash, I would just beg you to look more closely at this. I think it's an assumption that too many people have made without really having looked carefully at all of the numbers.
Okay, did you want to add something?
Well, I don't agree with them.
Oh.
Take a
The
look.
counties have a lot of money. Some of the money they got 5 years ago, they didn't spend. So there's built up. The reserves are built up by under expending the funds, and so they get built up. And so that's I think a prudent reserve is fine. And we established a new rule on that this year. So I think we're getting that under control, and we're getting the spending done. So.
But but it's not every county. I think you'll be.
No, it
there's
varies.
Some counties where it looks like there is a lot of money sitting there. Others, not so much.
And I would just want to jump in. It's a leadership issue also, and willing to take risks in Los Angeles County, where we have a visionary, energetic, thinks in the future leader. He's doubled the MHSA spending in the last 2 years. Yeah. And we now have innovations projects in the pipeline, whereas prior to that, there was like one. And the previous leader was siloed and hunkered down in a huge bureaucracy. So that's a leadership issue at the local level that we struggle with. And we're grateful that we finally have somebody with some vision in Los Angeles County. Yeah,
there's going to be Uber IPO bloom for the Mental Health Services Act this year. So.
let's see how that IPO does. It's not clear yet.
When all these millionaires are created, the Mental Health Services Act gets a big chunk of money. So that's the way kind of.
We had predicted there'd be 1,000 new millionaires in San Francisco. I think many of those 1,000 are not sleeping well at night this week. So we'll wait and see. Maybe more, but it could turn out differently.
Well, to kind of play off of those last comments, I'm curious about the people on the other end of the equation. So this questioner is asking, given that we know how much things like poverty and homelessness affect mental health and wellness, what existing or proposed solutions are there that tackle the impact of California's economic environment on individual and family mental stability?
Well, I'm always for going with the kids and early the screening, diagnose, treatment programs that you were mentioning. What's the federal match to that?
It's 50-50.
50-50. So if we invest, we only have to put up 50 cents for every 50 cents we get. We should screen, like you said, all kids that are eligible should be screened on all the mental health issues immediately. So it's an entitlement for the children that are eligible, and you say there's 6 million kids, and then develop individual treatment plans for each kid, and that could include the education. And we should have mental health programs in the schools. That's our bill, SB 582, and there's other bills that do that put mental health programs in the schools. So I think that's, to me, it's an entitlement and obligation that the school system and the mental health system work together. And it hasn't been easy, but it's taken 3 years to get them to agree with this legislation. 3 to 4 years. I get beat up every year by both sides, so it's hard.
I think I know that we're starting to fund, or at least MHSA is starting to fund more of the housing opportunities, and so using those housing first models, which really provide a house first, and that means wherever someone's at. So they don't have to be clean and sober. You really provide that house, and then you can provide the supports around that. Is definitely a start. The challenge with some of these things like the housing first model is like NIMBYism, like someone doesn't want that in their community. And so how do we partner with our consumer-run organizations or our NAMI to provide education to those communities so that folks can actually build? Because if someone can't build, all the housing first in the world doesn't do anything, because they will stop it at that local level, and it won't be able to thrive. So really finding a way to provide that community education, and then having that supportive housing, because if that keeps coming up, the housing, it's not going away. So I think that's one way, and really staying within the model, the real model of housing first.
I think people know the governor's put was 500 million. I think it's gone up now with the May revise for homelessness, specifically related to a serious mental illness. No Place Like Home is coming online tomorrow. We'll launch the homelessness commission that Darren Steinberg's going to chair. That it's there are a lot of initiatives around homelessness, and it's almost everywhere in the state, rural and urban. This is an issue that people care deeply about. So this has got the governor's attention, no question about it.
Justin, if I can make a quick point there, because I heard you ask this question I heard the question as, what is the role of the mental health system in addressing structural inequity? That's what I heard in your, the rich are getting richer, the poor are getting poorer. And so one is that stratification creates social dislocation. So we have to treat it. We have to acknowledge it. But what makes this movement so unique as well is it's a chance to build a healthcare system for people, by people. So if you accept this idea that we're going to do something big on mental health, like we got the all-stars coming, governor's down, some big thing is going to happen on mental health. If we return to this theme that people with lived experience are the way forward, what if this new mental health Camelot was built on the backs of paychecks for people with lived experience? What if we said we're going to do a $4 to $10 billion investment in a new mental health system, and half of it is going to land in the hands of paychecks for people with lived experience? Then you'd, by definition, be addressing structural inequity and creating economic power and opportunity for low-income folks.
They say empowerment heals. So that's part of a solution too. Empowerment in the community heals. It heals people, the community.
In working with a lot of the CBOs that I have, the one thing that folks who had lived experience said, I really need to work. I need to have purpose. I need to have meaning. I need to have a reason to get out of my house. And so giving them a paycheck and a reason to get out of their house and use that experience for good is amazing. And why not?
There are not enough therapists out there anyway, right? No. We all talk about the workforce challenge. Well, what if we flip that?
Yeah.
And see that as an opportunity to build a system for people, by people, and pay it that way? To me, there's a really unique kind of flipping of that frame that this current opportunity allows us to think about.
There are a lot of questions that are related to the question of conservatorship, which is obviously one of the most controversial debates in mental health, related to the 1967 Lanterman-Petra Short law. So is changing that law to allow for more involuntary treatment part of the answer? Why or why not? And if not, what is?
Well, it's an interesting question for me, because as I entered into my fellowship a couple years ago, writing on the stories of what we call the Hollywood Top 14, the most severely mentally ill. 6 of those people we advocated for conservatorship because that was the only way we could see a path forward for them to get from the street to a better place. And in each of those instances, we saw complete transformation, physical transformation, psychosocial transformation, almost as I would describe it, like a butterfly coming out of their cocoon, the person that they were made to be. Going to Trieste then and seeing where involuntary hospitalization even is an anathema. And what precludes all that is sincere connection with people by the same people over and over again, and a negotiation, as they would describe it, a negoziazione, to negotiate with people about their treatment, their medication, taking a shower, whatever it takes. I've seen, this is the only tool we seem to have right here to help people who are very, very sick. And we've had people die in Hollywood. And then there's this other way. So I'm kind of in this limbo land because right now this is a tool to help people who are dying on the street, and we know that they are left to their own devices, they are going to perish. But I've seen a model that is so incredibly human and beautiful that we could aspire to if we put our hands around it.
Personally, because I am someone who has been involuntarily committed, it didn't really work so well for me. And all that it taught me to do was to avoid hospitals. And so I think that a lot of family members don't have a lot of other options. And so if your option is like having someone die or, forced treatment, I'm empathetic, and I think that maybe we should have better options. Like, let's have peer respites, let's have peer run organizations, let's have SB 10 actually go through this time and have these solutions where we can really help people, because like I mentioned before, some of the things that happen when you are involuntarily committed, trauma, like rape, attack, like horrible things have happened to people in the name of treatment. And that's not what anyone wants for them. But without having a better solution, that's what we get. And I think we can do better. And better is not the criminal justice system. Better is not forced treatment. And, that's okay if you don't agree with me, but I'm here as someone who's been there and who's then now avoided that situation. When I really needed help, I didn't get it there, I didn't get it there. So why don't we actually find things that work and partner with people to see what works for them? I think we can be more towards solutions, more towards person-centered care, more towards what's going to help somebody. And that's just where I stand, and I always will, based on my experience and the experience of my colleagues.
I stand as parent of somebody who has developmental disabilities and schizophrenia. And I took with my wife, the NAMI parent-to-parent training program. And I think that before we put people involuntarily in a corrupt, incompetent system, we should support the parent-to-parent training programs, and we should not involuntarily commit people unnecessarily. So I'm very cautious about involuntary commitment without some kind of graduated program to inform families, to get that support system built up for the person. And we should support building up the system of family, personal support for that person. That, to me is a more humane, honest way of helping somebody, rather than just completely isolating them by putting some judge or some governmental institution in charge of the person's treatment, which is tantamount to incarceration. And I have a very limited view about involuntary commitment for that reason. I think we should have other options if we're going to go with these laws. I see them all the time. There's about 5 of them on the the Assembly and the Senate this year. Every year there's a bunch of them, you know. So I think the peer support programs and the NAMI family training programs and other things to encourage, if we just have a law that just said if your family member is in some kind of trouble, that you get notified. You know, just be notified if the family member is in emergency psychiatric or incarcerated or some kind of way of having the family be notified. Why can't we have some kind of limited conservatorship just to let a notification law, a law that says notify family members or allow the person to agree that that these people will be notified. Maybe it's a minister, maybe it's another person that cares about them, just somebody they can reach out to and connect with. I think those kind of laws should be established.
Yeah, we have, many states have used advanced directives here. And that is one way to, instead of treating this as an all or nothing situation, I love Kelly's comment because this is always the path of last resort. Nobody wants to get, and the fact that you're even having the conversation means you've got a broken system in some way. You're not getting there in time. But there are ways of managing that, and the advanced directive has been one that many people would say is a little more compassionate. Not ideal, but at least more compassionate.
I think with that, we give Dr. Insel the last word. Thank you all very much for a fascinating conversation. Appreciate it.
You know, you could come and testify on some of these.
Yeah. I know I want to be respectful of people's time. We really appreciate everybody coming out. Thanks to all the panelists for the work prepping for this and doing it. The most important piece of information I have for you is there's still lunches available in the back, so please take some food with you. Really want to thank, again, the Healthcare Foundation, Dr. Hernandez and her crew are here for making all this possible. The best thing you can do from here is to, if you haven't yet, read Jocelyn's stories, share them with other people, get the word out. We're going to share a link to the video, the broadcast of this. If you registered, it'll be emailed to you. If not, it'll be on our website. Join CalMatters, become a supporting member if you care to. That'll help us do this work as well. And like I said before, this is just the start of the conversation, so we look forward to more of it. Thanks very much.
Things can go wrong.
Okay.